Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Welcome to Central Line. I'm Dr. Adam Stryker, your editor and host. We're bringing you another episode with Dr. Jason Shi, one of the editors of ASA Summaries of Emerging Evidence, or SEE. The 42A issue is hot off the presses, so I'm going to ask Dr. Chi about some of the studies this issue touches on. Dr. Chi, welcome back to the show.
Thank you. Thanks for having me. Glad to be back.
Well, we're going to start with item 68 in the relationship between sedation type and the rate of precancerous polyp detection in colonoscopies. Why does this topic warrant our attention?
Yeah, this is a really great item from our latest issue of SEE. So this item deals with colonoscopies, and as we all know, colonoscopy is a very effective screening tool for detecting colon cancer. It is a very common procedure that's performed all around this country and all around the world. But we do know that it is uncomfortable for the patient and it requires sedation. And as anyone who has practiced anesthesia for any amount of time knows, we have all seen a very, very wide variety of clinical practice when it comes to types of sedation. Chiefly, it divides into two types. One is propofol-based sedation, and the other is sedation, which is delivered without propofol. And propofol-based sedation obviously is almost always provided by an anesthesiologist or a CRNA due to the dangers that are inherent to propofol and which are familiar to all of us. But interestingly, there have not been many previous studies which have explored whether the type of sedation is associated with differing rates of detection of precancerous polyps. And that is actually the exact subject that this item touches on.
Great. Well, tell us about the recent study. How does this fit into the larger context, and what can we glean from it regarding the type of sedation for these procedures?
The study was published in Anesthesiology in June of 2024, authored by folks from Tufts and Dartmouth. It is a retrospective study that looked at over 50,000 colonoscopies in the state of New Hampshire. And the study author specifically asked, hey, is there an association between the type of sedation, namely propofol-based sedation versus non-propofol-based sedation, and detection rates of precancerous polyps? The larger context of this is that this study is especially timely, given that health insurance companies have numerous times attempted to deny payment or reduce payment for anesthesia services for endoscopic procedures. The most notable example of that was in January of 2024, when Blue Cross Blue Shield of Massachusetts put out a policy that said they would no longer pay for anesthesia care for ASA physical status 1 and 2 patients. And a couple of months before the policy was actually implemented, there was so much backlash from physicians, actually from patients and from the general public, that Blue Cross Blue Shield of Massachusetts paused this policy indefinitely at the end of January. And then they haven't gone back to that yet, but there have been numerous other examples of other insurance companies attempting to use other more subtle approaches to limit anesthesia involvement or to reduce payment or deny payment to anesthesiologists or anesthesia care providers for endoscopy cases. And undoubtedly, in the minds of insurance companies, this is a cost that can be reduced and then is perhaps not necessary. If the patients can get by with moderate sedation, then why do they need an anesthesiologist? So that's part of the larger context of what this study is looking at, but it's also a pure question also of, hey, if we do propofol-based sedation, does that lead to better conditions such that the endoscopist is going to be able to detect these precancerous lesions at a higher rate? So that's what this study is touching on.
Well, let's get into the details of the study then. What did the authors find?
So once again, it's a study that utilized something called the New Hampshire Colonoscopy Registry. It is a registry of 30 endoscopy practices in the state of New Hampshire. The dates of the study were 2015 to 2020, so about a 5 to 6 year time period. 54,063 patients, so quite a large sample size. Notably, 54.2% of the procedures, about half, were performed with propofol. So about half of the colonoscopies in the state of New Hampshire were performed with propofol-based sedation. The study hypothesis was that propofol-based sedation would result in enhanced polyp detection. So, in other words, a higher rate of polyp detection. And the hypothesis was like that because they hypothesized that procedural conditions would be improved with the use of propofol-based sedation. And so they would have a bit more time and a patient who is perhaps not as moving as much to be able to detect harder to see polyps. I should make a mention that the study does differentiate between adenomatous polyps and serrated polyps. And serrated polyps are typically more difficult to identify. They're flatter. A lot of times they're covered by a mucus cap. And so the study authors specifically hypothesized that the performance of detection of polyps would be improved specifically for serrated polyps. And they made that as a separate hypothesis.
All right. Well, let's analyze what exactly we can take out of the study. What were the findings that were pertinent?
The study outcomes were detection rates of neoplastic polyps, which included all adenomas, all serrated polyps, and then separately adenomatous polyps, and then separately serrated polyps. So for the entire sample of 54,063 patients, they did find a higher rate of serrated polyp detection in the propofol group. So in the propofol group, it's 34% versus 24% in the moderate sedation-based group. The study authors also conducted what they call a restricted sample analysis. And the reason they did this was because a lot of the facilities and endoscopists had very polarized usage of propofol. Some of them use propofol almost never, less than 5% of the time. And some facilities and some endoscopists use propofol almost always, meaning greater than 95% of the time. And so once again, this demonstrates what I had mentioned earlier, that there is, as we've all seen, very wide practice variation in the usage of sedation and in the type of sedation for lower GI endoscopy. So what the study authors did was, they said, well, let's take this entire sample and let's look at only the samples of cases where facilities and endoscopists had usage of propofol that wasn't so polarized, that wasn't never or always. It was a mix. Sometimes they use propofol, sometimes they use moderate sedation. And let's see what the results of that sample are. And in that restricted sample, they found the same relationship again. They found that propofol-based sedation was associated with higher rates of detection of serrated polyps versus when moderate sedation was used. And so the study authors said that there was, quote, a higher likelihood of serrated polyp detection, end quote, when propofol was used versus moderate sedation. And so this is a pretty striking finding. It really aligns well with what the study authors had hypothesized, that the serrated polyps, which are more difficult to detect and perhaps require a greater degree of patient stillness or procedural expertise, they had found a higher rate of serrated polyp detection in the propofol-based group. They had also performed various alternative analyses where they corrected and accounted for various factors, confounders, clustering of patients, many different types of analyses. I'm not going to go into the nitty-gritty of all that here, but they found that that relationship, the propofol-based sedation and higher rate of serrated polyp detection, persisted in all the alternative analyses, which really strengthens that finding.
We don't have obviously the time to get into all the nitty-gritty, but stepping back and broadening this out just a bit, it certainly seems like a study like this would be strong ammunition to convince the insurance companies that this would be beneficial. Not only is it obviously beneficial from a patient care standpoint,
right?
But even if you were looking at it through the lens of financial analyses, you would think insurance companies would look at this and say, this is actually going to probably save us money in the long run if we can detect these things earlier.
Right. You're absolutely right about that. I think that's a very reasonable conclusion to come to, is that, hey, if we get better at detecting these precancerous lesions, then we can detect cancers earlier and, save costs down the line, in addition to the obvious patient benefits. The study authors of this study do mention that serrated polyps, like I had said before, can be more challenging to detect, but they can also be precursors for up to 30% of colorectal cancer. So these are not benign situations, and these are not benign findings. So I agree with you, Dr. Stryker. This is definitely something that patients and patient advocates and physicians like ourselves would say, hey, this is not just a matter of patient comfort, but this can actually lead to a faster and more frequent diagnosis of precancerous lesions.
Well, let's shift gears a little bit. Turn to item 85, which is about 30-day mortality in patients with chronic kidney disease who received rocuronium and Sugammadex versus cisatracurium and neostigmine. Why does this specific topic warrant our time and attention?
Well, as you can see from your question, so we had chronic kidney disease in there. So chronic kidney disease, unfortunately, very common in any patient population. Rocuronium, Sugammadex, this is, goes without saying, this is our bread and butter. We use these medications and almost on a daily basis. Cisatracurium and neostigmine used to be very common. We used to use them all the time, but medications that are very familiar to all anesthesiologists. So these are 4 very commonly used drugs. Bread and butter, this is a regular part of our toolbox. Chronic kidney disease is unfortunately something that we see very commonly. And so the combination of chronic kidney disease, rocuronium, Sugammadex, cisatracurium, and neostigmine, any kind of study that looks at that with an association with 30-day mortality is going to have very wide applicability. And so the study findings of any type of study that involves all of those factors is going to have potentially a very broad impact.
Okay, well, this SEE item is about a recent retrospective observational study comparing patient outcomes between these 2 regimens of neuromuscular blocking agents and reversal. Let's get into this study and give us a little bit of background first, and then we'll go into the findings.
So the background is that Sugammadex, as we all know, it's a relatively recent drug when we're comparing it to rocuronium or cisatracurium or neostigmine, which have been around for decades. And many anesthesiologists are unaware that the manufacturer of Sugammadex actually recommends that it not be used in patients who have, quote unquote, severe renal impairment. And just reading from the package insert, it says, Bridion is not recommended for use in patients with severe renal impairment, parentheses, creatinine clearance less than 30, due to insufficient safety information. And the other point is that Sugammadex is, quote unquote, substantially excreted by the kidney. The half-life of Sugammadex is 4 hours in mild renal impairment, but up to 19 hours in severe renal impairment. And in fact, Sugammadex can actually be detectable in the blood up to 48 hours after a dose in a patient with severe renal impairment. So Sugammadex could be hanging out all the way out in a patient's body up till post-op day 2 in a patient who has severe renal impairment. However, based on my anecdotal data and just based on my observations of the clinical practice at the hospitals that I work at, I've seen that rocuronium and Sugammadex are widely used in patients who have renal insufficiency anyway. And so given that Sugammadex is, like I said, a relatively newer drug, there aren't a lot of studies which report its safety profile in specific patient subsets, such as patients who have severe renal impairment. And that's where this study sort of fills that gap.
Now, let's take our listeners through a little bit. I can certainly understand why a lot of practitioners would continue to use it in this instance, given the risk of residual neuromuscular blockade and the success or efficacy of Sugammadex. Take us through a little bit what the potential, before we get into the study itself, the potential for Sugammadex sticking around as an efficacious drug in the body for that significant period of time in someone with renal insufficiency.
Yeah, like I mentioned before, there's not a wealth of data. In fact, there's not much data at all about Sugammadex, specifically in the subset of patients who have severe renal impairment. We know that rocuronium has renal excretion and hepatic metabolism, biliary excretion. However, when rocuronium is complexed with Sugammadex, it has to be excreted by the kidney. And so that's where sort of the question mark becomes, well, if we have a patient who is end-stage renal disease on dialysis, if we have a patient who has severe renal impairment, what's happening to that Sugammadex rocuronium complex? It needs to be treated renally, but it's sort of an unknown. We don't know, does that complex of rocuronium Sugammadex, does that remain complex for the entire time? Does that complex dissociate? We just don't know. So that's why this study was really interesting to me, because it studies an actual hard outcome. So 30-day mortality and post-op complications. And those are hard clinical outcomes that we can look at while science is still figuring out the answers about what happens to Sugammadex and rocuronium in a patient who has severe renal impairment.
Okay, so let's get into the specifics of this study then.
So this study, it was published in Anesthesia and Analgesia in 2024. It is a study from the anesthesia department at UT Galveston, a retrospective cohort study and a propensity matched. It is from a database which included 50 healthcare organizations in the US. They constructed 10,000 patients in 2 separate cohorts, so 10,000 patients each. And all patients in the entire study had chronic kidney disease as defined by ICD-10 classification. In one cohort, which they call Cohort A received rocuronium and Sugammadex at some point in their perioperative course. In Cohort B, they received cisatracurium and neostigmine at some point in their perioperative course. Their metrics were looking at respiratory distress, hypertensive crisis, heart failure, pleural effusion, 30-day mortality, cardiac arrhythmias, acute MI, pulmonary embolism, and acute kidney injury. And so they were looking at sort of a wide spectrum of metrics. And they found, interestingly, that patients who had received the combination of rocuronium and Sugammadex had worse outcomes in acute respiratory distress, hypertensive crisis, heart failure, pleural effusion, and even 30-day mortality. And so these were outcomes that were statistically significantly worse in the patients who had received roc and Sugammadex as compared to patients who had received cisatracurium and neostigmine. Interestingly, they did not find any significant differences in some of the other outcomes. So the outcomes in which they did not find any differences were cardiac arrhythmias, acute MI, pulmonary embolism, and acute kidney injury. So sort of a mixed bag in terms of the outcomes, but definitely enough of a signal there that it would really sort of pique my interest.
It's an incredibly interesting finding. When you think about it, before Sugammadex was so prevalent, I think most practitioners would reach for cisatracurium or something along those lines in patients with renal insufficiency.
Sure.
It would, and it certainly is interesting. The ubiquitous nature of usage of Sugammadex has caused us to probably inadvertently maybe assume more risk with these patients by using rocuronium, given that we feel that it is a safer reversal agent with roc. So it's obviously so much more work needs to be done, but that what you're describing certainly suggests that somehow contributing to these findings.
Yeah, I echo your thoughts as well. It's really been an interesting transition because I trained before Sugammadex. So, I trained with roc and VEC and cis, and we reversed the patients always with neostigmine and glycopyrrolate. And I've seen that transition to Sugammadex, and I agree with you. It's just so easy to use, and it's so effective, just clinically speaking. And so I think the combination of the ease of use and just the overwhelming effectiveness of it has really just revolutionized clinical practice. And neostigmine and glycopyrrolate are really just sort of relics of the past. I work with residents all the time, and when I suggest using neostigmine or glycopyrrolate, their eyes just get really wide, and they say, "Well, oh wow, I've never done that before." Sometimes
how do you dose
these are
that?
CA3 residents that have never used it before. Yo, we better use it. I want you to use it at least once before you graduate.
Exactly.
Yeah. I did have a chance to just peek at the article real quick, and I'm looking at the source article, and they mention in their results section, the 30-day mortality, they have a risk ratio of 1.31 and a number needed to treat of 156 and a p-value of 0.0021. So fairly significant, number needed to treat of 156, out of 156 patients. Yeah. So pretty dramatic findings, I would say.
Now, did the authors make any mention in the discussion about what you had talked about earlier, the biochemical complex potentially causing any issues?
Yeah. So yes. So the authors do go into what may have contributed to this finding. So like I mentioned before, but I'll just go really briefly into it again. Rocuronium, we know renal and hepatic excretion. Once it's complexed with the Sugammadex, it must be excreted renally. There was one previous study that looked specifically at neostigmine versus Sugamidex with relation to kidney function, but found no differences in any of their side effect profiles. We do know that Sugamidex has been associated with hypotension, bradycardia, and even negative pressure pulmonary edema. And so we know that's a risk with it. It's not a very common risk, but we do know that happens. And one other thing that I found very interesting that the study authors mentioned was that previous studies have found that rocuronium is associated with pro-inflammatory effects. So increase in levels of IgE and C-reactive protein. And even more interestingly is that, and I did not know this, was cisatracurium has been found to have anti-inflammatory effects and induces decreased levels of inflammatory cytokines. So the study authors also put that out there and, posit, is this a possible contributing factor to these outcomes? So,
Well, and like most studies, it is a springboard for further work. How do you put this study in that framework? How would you classify this in that regard?
Yeah, absolutely. And that's how I would classify it. That's exactly what I would say was, I would say this is, only one study. It is a compelling study because of its size. And it also tracks with the manufacturer's recommendation against using Sugamidex in patients with severe renal impairment. But we do have to keep in mind it's only one study, and we do have to consider the entire body of available medical literature, as sparse as it may be for this particular topic. My takeaway from all of this is that I think we do need to be maybe a little bit more thoughtful about our usage of rocuronium and Sugamidex in patients who have severe renal impairment. So specifically GFR less than 30 and patients who are on dialysis. Certainly in my practice, I tend to try to avoid rocuronium and Sugamidex in those patients. And the other reason is that there exists actually a perfectly acceptable alternative, that being cisatracurium and neostigmine, as unfamiliar as it may be to our younger colleagues, but it still exists and it's still in the cart. That's my takeaway from it. I think it's a very interesting study, and I really hope to see more studies of rocuronium and Sugamidex in patients who have renal impairment, because, like I said, this is a patient population that is very large, and these are medications and drugs that we use every day. So the clinical implications would be very broad.
Yeah, absolutely. Very interesting findings. Well, before I let you go, if you don't mind, tell our listeners a little bit more about the 42A issue. Are there other topics or specific items that you think would be worth them looking into?
Sure. There is one other item that I found of great interest to me. It's item 48. And just for the benefit of our listeners, each issue has 100 multiple choice questions and discussions. Each multiple choice question and discussion is based on a specific article from the recent medical literature that is clinically relevant to the practice of anesthesia. And so item 48 in this issue is about a randomized double-blind clinical trial performed at the University of Miami, in which they compared the dosing of protamine, 250 milligrams of fixed dose of protamine, versus a 1:100 dosing regimen for the reversal of heparin for patients with adult cardiac surgery with bypass. There were 62 patients in one group, 63 patients in another group, and their primary study outcome was post-protamine ACT, and one of their secondary outcomes was 24-hour chest tube output. And interestingly, they found no difference in any of the outcomes. So they found no difference in the ACT values post-protamine, and they found no difference in the amount of chest tube output at 24 hours after surgery. It's interesting because I have long felt that we give too much protamine after cardiopulmonary bypass, and protamine in and of itself actually has intrinsic anticoagulant properties. And so protamine in excess can actually theoretically cause bleeding. And there is a bit of an emerging body of medical literature which is suggesting that maybe we're giving too much protamine. And there are actually several studies out there that are suggesting that perhaps the sweet spot of protamine dosing vis-a-vis heparin is perhaps 0.6 or 0.7 of what the heparin dose was. So anyway, I don't want to get into too much detail about that, but I thought this was a very interesting study, very nicely done, prospective, randomized, double-blind clinical trial from University of Miami, where they compared two dosing regimens for protamine and found that the lower dosing regimen was just as effective clinically as the higher dosing regimen. So lots of great stuff in this latest issue. And I use SEE myself for CME credits, and I think it's fantastic. And I can't recommend it highly enough for all of our listeners.
Well, it's another fascinating study. It sounds like the 42A issue is chock full of really interesting and great information.
Yeah. Yes.
Which is a great segue for our listeners, that if anyone is interested in checking out SEE, whether they're familiar with it or they just want to check it out for the first time, the site to check out is www.asahq.org/SEE. Dr. Chi, thank you so much for sharing some of the information and a little bit of a peek into the current issue of SEE. It is such a wonderful program, and every time we talk about SEE on this podcast, I'm reminded of just how much interesting information we can gather from this program. So thank you so much.
You're welcome. Thank you for having me on.
And to our listeners, please tune in again next time for Central Line. Thanks for joining us this time, and we will talk soon. Take care.
Hello, ASA. I'm Dr. Patrick Guillaume, your ASA president, and this is the Monday Morning Minute with recent highlights from the Monday Morning Outreach. First up, anesthesiologists are paid by Medicare less than 1/3 of our fair market value. ASA is working with Congress to get an annual inflation adjuster, which would set Medicare on a better path forward. Next, I attended the AMA State Advocacy Summit in January. We will leverage our relationships with legislators and within the House of Medicine to drive our agenda. Last, ASA is accepting applications until February 9th for the Resident Scholar Program in Political Affairs and until February 28th for the Anesthesia Quality Institute Resident Research Rotation. These are funded and residency credit rotations. Well, that's enough for now. Thanks for listening, and I hope you'll follow us on your favorite social media channels and check out my weekly Monday Morning Outreach.
For more detailed and timely information, don't miss Dr. Guillaume's Monday Morning Outreach email delivered exclusively to ASA members' inboxes every Monday at 5 a.m. Eastern. Discover the most important emerging knowledge from around the globe, including key insights and specialty advancements you can apply to your own clinical practice. Through 200 multiple-choice questions and discussions, this engaging program helps you enhance your knowledge whenever you have a moment free. Try a sample question at asahq.org/SEE. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.